usually the trigger that occurs for an induction of a ventricular tachycardia in a clinical setting is a PVC. In a laboratory setting is what we call it as extra stimuli. So you often we ask, but you can question me on the second day or the third day of myocardial infarction, we find monomorphic VT. Where is the scar in the VT in the second day of myocardial infarction? It is simply not possible. So then what really happens in this subset of patients? If you look at this picture, so here on my left side, you see a small muscle draining into a large muscle. There is an abrupt change in the diameter of the muscle. For this muscle to depolarize the other side of the muscle,
pointer, please. Can you use a pointer?
Yeah. So there is a small muscle which is connected to a very large muscle. For this muscle to depolarize this muscle, it has to supply enough charges to depolarize this muscle. Usually in the diseased myocardium, this cannot happen. So what really happens here is a conduction block. You see, this side of the impulse is not able to come to this side is not able to come to this side. So no problem. There is a conduction block on both the sides, and this is not going to do anything to the heart. Suppose you come to the right side of the picture, where you see on the green arrow marked, the diameter of the muscle increases gradually. So whenever the diameter of the muscle increases gradually, the positive ions supplied are just enough for the conduction. So here there will be a slow conduction that will be going on. Here there is a conduction block. So this is called a source sink mismatch. This concept is called a source sink mismatch, and this is a perfect milieu for occurrence of a ventricular tachycardia, either in an acute inflammation or in early stages of myocardial infarction. So this is one more picture to emphasize how a scar produces delayed conduction or a slow conduction. If you look at this picture, so you see that the myocardial cells are arranged in a brick-shaped fashion, where the predominant conduction happens longitudinally. In the end-to-end conduction happens, but there are also conduction that is occurring in a transverse way. So as such, a conduction in the myocardium is an anisotropic conduction. But what happens in a diseased state? Suppose you replace this amount of myocardium and these intercalated discs with a lot of collagen fibers. What you see is, for the same distance to traverse, this impulse takes a very long time. It goes roundabout and roundabout, creating a very slow conduction and preparing the substrate for a ventricular tachycardia. So what I've put in this, you can see in this nutshell in this picture. So here is this dark gray block is the conduction block or an anatomical block. So what here it has happened is, the blue impulse has come down, it has divided into two, but it got blocked here, whereas this has conducted, so this has conducted this way and it has come. So at the moment when it returns here, the refractory period has gone and this tissue is now amenable for conduction. So this has set in the reentry. So this, the same picture I have depicted how a sourcing mismatch can cause a conduction block and it can cause a reentry. But in a classical sense, often when the electrophysiologists they talk regarding a scar related ventricular tachycardia, they always talk about what is called as figure of 8 reentry. So I'll just briefly tell you what is figure of 8 reentry. The figure of 8 reentry is nothing but there is a two scar zones. It need not always be a scar, it can be a conduction blockage also. In between two scars there is a tissue called as isthmus. If you ask me the property of this isthmus is a very slowly conducting zone compared to the rest of the myocardium. So what really happens here is this is called as the circuit, and this sets the reentry mechanism. So what really happens when the myocardium slowly conducts this way, so it exits through the normal myocardium, but this conduction around these two scar regions goes roundabout, and this is called as figure of 8 reentry. The one point I would like to say here is, whenever anyone talks about the morphology of the ventricular tachycardia, let it be focal or reentry, always the morphology of the reentrant tachycardia always correlates with the exit. So it is this portion of the depolarization and further above depolarization, which determines the morphology and not what is going on in this circuit. So there are other forms of reentry can occur. It is not always that myocardium needs to be reentry, having the reentry property. You can also have a conduction system which can have a reentry property. This is a fascicular VT, that is posterior fascicular VT. So here what happens is there are two tissues. One is the native conduction tissue, and there is an adjacent tissue, that is an extra tissue, which also has a conducting property. So here what happens, the impulse goes up and come down, creating what is called as fascicular VT. So not only in this way conduction system can be involved, there are other ways in which the conduction system alone can produce reentry without proper involvement of the myocardium. So this is a post aortic valve replacement patient. You can see the patient has developed a complete left bundle branch block. This patient subsequently developed VT also. But when you compare these two morphologies, what is very striking is the morphology of the VT and the morphology of the baseline, that is the native rhythm, both are same. How can this happen? This usually happens in the setting of a diseased conduction system. So what really happens is, suppose I deliver a premature ventricular complex from the right ventricle. This can so what it does is, the normally conducting right bundle doesn't allow it to ascend up. So in turn, how this premature ventricular complex exit from the myocardium is, it traverses the interventricular septum and it ascends the left bundle and it comes. So this forms a circuit, and this is called as bundle branch reentry ventricular tachycardia. So how do we utilize this in the electrophysiology laboratory? We know that we need two tissues with a variable refractory period or a variable conduction properties. So I assume the one on my left side has an effective refractory period of 200 and one on my right side has an effective refractory period of 400. So I deliver an extra stimulus at a 450, that is a PVC at a 450 millisecond. So what really happens is, since 450 is well above both 200 and 400, both will conduct through both the pathways simultaneously. What will happen if I deliver 150? The 150 effective refractory period is far lesser than the refractory period of each individual pathway, so it gets blocked. But it is not useful to us, because in an electrophysiological laboratory, you need to induce ventricular tachycardia for you to map, ablate, more importantly to decipher the mechanism. Suppose I give a PVC at 300 millisecond coupling interval. So what really happens here is, the 300, so here it is 200 to 400, the 300 here it conducts, because 300 is well above 200, so this side of the pathway conducts, but this side of the pathway blocks. So one side there is an unilateral blockage, other side there is a conduction. So this sets the milieu for reentry. So this is how we use the property of the individual muscle with varying conduction properties to bring the ventricular tachycardia in the laboratory. Having said this, how do we manage the ventricular tachycardia as such? So for any ventricular tachycardia, we commonly divide into idiopathic or structural. Structural means in the presence of any myocardial disease. So initial therapy for majority of the VT, we will drug therapy. Other options that are available are catheter ablation. One more option is sympathectomy, apart from the reversible causes that we have to correct in every VT. So how are we going to map the VT and do the catheter ablation is what I'm going to speak in next few minutes. So what is the goal of the mapping? So you have taken a ventricular tachycardia patient who is refractory to drug therapy. So first is to identify the mechanism of the ventricular tachycardia. Either it is focal or reentry, as I described above. Because for a reentry ventricular tachycardia, your first and foremost job is to identify the critical isthmus. As I said earlier, the critical isthmus is the very vital structure. So if you target the critical isthmus, which is very small and which is easily ablatable, you can cure the patient of ventricular tachycardia. So that is the purpose of my mapping in the case of reentry uh, VT. So how do I go about? So any VT, it can be hemodynamically stable or hemodynamically unstable. Whenever the patient is a hemodynamically unstable VT, I am not going to induce the VT in the laboratory. So how am I going to map these areas? So what I'm going to do, two types of mapping I'm going to do in these patients. So the one is called as substrate mapping. I'm going to identify the areas of the scar and the intervening myocardial cells that is alive in the scar and ablate or deliver the radio frequency energy and cut this circuit off. And the other method I use is called as space mapping, which I'll be describing subsequently. Suppose the ventricular tachycardia is very stable in the electrophysiology laboratory. So what is that I am going to do? So I am going to place multiple catheter in the heart. I am going to study how this ventricular tachycardia activate. I am not only going to study the activation pattern of this ventricular tachycardia and identifying the substrate. One more important thing I'm going to do is I'm going to prove that this ventricular tachycardia is due to reentry. Because if I prove the reentry, my job gets easy because I am just going to target the isthmus plus or minus other substrates. So what do we do to prove the reentry of the tachycardia? We do a maneuver called as entrainment, which most of you must have heard. So first is the substrate mapping. The substrate mapping is done during the sinus rhythm. So what is the premise of the substrate mapping? So if you look at this picture, so this is a picture of a infarcted myocardium. You can see the scar with various shades of blue. So it is not uniformly scarred tissue, and in between you can see the red muscle intertwining. So this is the surviving myocardial cells. So the proposed site of reentry in this patient is this area where the zigzag line that I have drawn. But without a running VT, you cannot really identify this site. So there are other ways to identify this kind of a semi-infarcted area or a viable area which sustains the circuit. So if I ask anyone, what is the marker of a scar in an ECG? Readily we will come up with an answer called as reduced QRS voltage, or a fractionation. These are the two answers we commonly give, or the poor progression of the R wave. So what is the electrophysiological equivalent of these two things in the EP lab? So not scarred, what I do is I take the catheter inside the heart and I record what is happening exactly in this very area. So instead of ECG, what I'm going to read is called as, what I'm going to learn is called as electrogram. I'm going to study how the electrogram looks like, what is the voltage of the electrogram, what is the morphology of the electrogram, very much like the ECG. So what is the next step? So what really happens? So I have put a 3 myocardial muscle bundle. As I said earlier, if there are no collagen, the brown color is represented by the collagen in between. If there is no collagen in between, even the transverse conduction would have happened. But what has really happened here is, instead of going like this, the myocardium has taken a detour of a very long conduction. So whenever there is a very long conduction, how my electrogram represents, my electrogram duration also increases. Instead of a very crisp electrogram of the electrogram A, which I have depicted, my catheter will record signals such that it will record a very long electrograms. That is, it's like a very long QRS that we see in a dilated heart. So what am I going to do with this? One more aid to our mapping strategy that we call it as electroanatomical mapping. You must have seen all these colorful figures. So I am going to measure the voltages, how much voltage these areas refer, and I am arbitrarily going to divide these areas into a scarred zone. A scarred zone is nothing but when the voltage is less than 0.5. And I also define the normal zone, that is when the voltage is more than 1.5. So this is the total voltage where my cursor is moving. So in between the area where there are shades between the red and the purple it's a semi-infarct zone. These I call it as borderline zone. So once I identify both these zones and the abnormal signals, my task relatively becomes easy. So I try to variably define these kind of an electrocardiogram electrogram, and I deliver ablation lesion in these areas, thinking that these are the areas that are going to sustain the VT during an actual clinical VT, but I don't have proof. But the substrate mapping alone cures ventricular tachycardia as high as 70%. That means there is no recurrence in 70 to 80% of the patient in a non-ischemic cardiomyopathy, and more than that, the success is higher in the case of ischemic cardiomyopathy when we do this kind of a substrate modification alone. So, but I still wanted to confirm whether the substrate is leading to something or not. How do I compare? So I do what is called a space mapping. So what is called a space mapping? Already I have the clinical ventricular tachycardia in the form of an ECG, or you could have very briefly triggered that ventricular tachycardia and decided, okay, I'll stop. I no more induction of ventricular tachycardia because of the hemodynamic instability. So you have some kind of a photo or a picture of the VT. So what I do is I keep on pacing at different sites that show this kind of a low voltage or an abnormal electrogram and try to match with the VT. This is called a space mapping. So space mapping is nothing but I'm going to pace and match with the clinical VT. When if both these things are matched, then I can reasonably assume that these are the tissues that is giving rise to this ventricular tachycardia. So you can see this is what we call as template. So we got this VPC. So you can see the lead 2, 3 and AVF is showing a positive deflection. And there are two panels, one in the middle and one in the extreme right. If you look at these two panels, above it says 99 and on the right side it says 95. What does the number means? You can also see visually. So what I have done here is I have taken this PVC and I have taken the pace mapped morphology and I have tried to superimpose on each other, and I have seen the matching. So you can see the middle panel from the site where I have paced, it is almost 99% matching with the ventricular tachycardia. So this is the probable and the most important site where I am going to deliver my radio frequency ablation. So this is with the substrate mapping and the pace mapping. So one of the downside of the pace mapping is, suppose you consider this is the ventricular tachycardia circuit. I am right in the middle of the isthmus, that is slowly connecting zone. So you can see there are 4 exits to this ventricular tachycardia, and as I already mentioned that exit is the one that determines the morphology of the QRS. Sometimes if the actual VT is exiting through this way, my right hand side, but when you pace, if it exits through the left hand side, then you may be for a fix and it might lead to confusion. So that is the one downside of having a pace mapping. Next and the most important and the fascinating concept is entrainment mapping. For an entrainment mapping to do, you need the first and foremost prerequisite is you need a stable ventricular tachycardia of a uniform morphology. So what is the meaning of an entrainment is the capture of the reentrant VT, which is already going on or rounding about in a circuit from a different site. What is the different site? I am putting a catheter in the circuit or near the circuit, or yes sir, I'll finish in, or a far away in the circuit, and I'm going to pace and capture this ventricular tachycardia, and I'm going to study the characteristic. Let's see how it happens. So use of the entrainment is 1, I prove the reentry, and number 2, I identify the critical area of the isthmus to make my ablation job easy. So in any ventricular tachycardia, as I said earlier, there is a head end and it's a tail end. So the head end is the activation wavefront and the tail end is the one, the receding wavefront. In between this head and the tail end is what is called as excitable gap. So this area of a tissue, if I pace at an appropriate timing, I will be able to enter, not only enter the circuit, I will also be able to capture the complete circuit and replay. Suppose if the tachycardia is running at a cycle at 300 millisecond, and if my pace is at 270, in this gap I will be able to enter and capture the circuit. So what really happens is when I deliver a circuit, it splits into 2. So one side it encounters the VT and it gets extinguished. On the other side, it goes through like this and goes through this slow pathway so that it doesn't get caught up with the tail, and it completely overtakes what is the called as entrainment. So the paced rhythm completely overtakes the ventricular tachycardia circuit. So this is called as entrainment. So one more concept I would like to introduce in an entrainment is post-pacing interval. So before I say some other characteristic of entrainment, what is a post-pacing interval? So when I stop the entrainment, the important prerequisite is the tachycardia should continue. So between the picture A and B, what is the difference? The stars represents the pacing site. Suppose if you look at the picture on my right side, and if I am pacing from here, I go this way, I entrain, and after I stop the entrainment, the native VT resumes. For the native VT to reach time for my recording electrode to record, that means I am far away from the circuit. On the contrary, if you look on the left side, I am in the circuit and I am pacing. So when the VT returns, the VT, I will immediately record the VT without any delay. So this will have a very short post-pacing cycle, where the post-pacing interval here is long. That means the pacing site is far away from the site of ventricular tachycardia. So before I complete, there is one more concept. It's called as fusion. Whenever there are two wavefronts, you know that for a fusion to occur, there are two wavefronts required. So on the left hand side, what you see here is the rectangular boxes are the stimulus that is delivered for the entrainment. So on the right hand side, what you see, you don't see such a stimulus. So this is a native ventricular tachycardia that is occurring. So what really happens is, here is my stimulus recording site. So what here is, after 388 millisecond, I have recorded this stimulus. And when I see the VT that is occurring, that is also at 388. So if I subtract both of this, it comes to 0. So my post-pacing interval it's literally 0. That means that my recording site or the pacing stimulus site is exactly at the slow conducting zone or in the circuit. So one more important aspect that you have to note in this is, you can note that the morphology of the ventricular tachycardia on the right side of the panel and one on the left side of the panel, it exactly matches each other. So what does it mean is, both the wavefronts by pacing and also VT, it travels in the same way. So this is called as entrainment mapping. By this we identify the isthmus and then we ablate at those sites. Thank you, sir.
Dr. Narasimhan, we can discuss this for 10 minutes, although we are slightly over time. It's worth discussion.
Yeah. Thank you very much, Vikram. I think I fully agree that time given was a little short, but we wanted this to more general audience. So we would like to take some of the clinically relevant questions. I have Dr. Karthikeya with me, who can address some of the questions which have come from the chat box. But first and foremost is, I would like you to understand that there is a lot of clinical utility in understanding the mechanism. For example, when the tachycardia, when you see in an acute myocardial infarction, it accelerates and then slows down, its automaticity. It doesn't respond to repeated shocks. You'll only increase the cardiogenic shock in a given patient. Similarly, when you see a PVC and then a long pause and then the tachycardia gets induced, the mechanism is triggered activity. Why is this relevant? If you prevent a pause, you can prevent a VT storm. Similarly, if you have a patient where the PVC is happening very late after the T wave, in a person who is on dobutamine, 9 out of 10, that is delayed after depolarization. You are giving too much of dobutamine or too much of digoxin, and it's calcium mediated. There are specific ionic blockade. For example, carvedilol blocks the calcium release. So looking at the ECG and deciphering the mechanism helps you a lot. Similarly, for example, certain syndromes where, for example, are associated with repolarization related VFs, they paradoxically respond to cooling of the body. You need to induce hypothermia to settle down the storm. So these are broad clinical concepts. The same thing that Dr. Vikram said, if you decipher the mechanism is because of slow conduction, and you give a drug which will further slow the conduction, for example, a procainamide or flecainide, it will worsen the VT. But if it's due to automatic VT, it will prevent the VT. So it has significant implications on patient management. I'll request Dr. Karthikeya to address the questions that have come from the chat box.
Thank you, Dr. Narasimhan. And I think Vikram did a wonderful job considering the time given was too short for the topic. But there are some questions from the chat box, and then maybe we'll discuss some more. So one of them is, how will you know a single entry and exit versus separate entry and exit site in a reentry circuit? So now when we talk about reentrant circuit, as Vikram showed, there is a scar and then there is an entrance and then there is an exit. Now from the surface ECG, as he rightly pointed out, what we only get to know where the VT circuit is exiting, and that will tell the ECG QRS morphology will tell you the exit site of the VT. That doesn't mean that if we ablate in the exit site, we find the circuit on entrainment and activation mapping, and then we ablate at the exit site, we are likely to be successful, because the reason is that the exit site may be much larger, and you cannot ablate in small area to get a successful result. And the reason why the isthmus site succeeds when we ablate at the isthmus site is because it's a small area of slow conduction, and when we ablate it, the circuit gets broken. Now, so the way to decipher that is by entrainment mapping, but since it is made, the talk is for the general audience and for DMDNB, that is, I think, not the scope of their syllabus. So we'll let that be. And but just to understand that exit site does not mean that that is the site of the ablation. The ablation in a reentrant circuit will be somewhere away. And that also gives you a very interesting features. When we see paced QRS morphologies during entrainment, we find that the QRS actually starts much later. And that actually intrigues many of the fellows and DMDMBs. They feel that this spike, pacing spike, has not captured. That again should be understood very clearly, that this pacing spike, if it is in the slow conducting area, it will take some time to exit, and so you need to measure the cycle length of the pacing cycle length and the cycle length of the QRS complexes to know whether you are actually capturing or not. If there is an interval from the pacing spike to the onset of QRS, that does not necessarily mean that you are not capturing. So that point should always be borne in mind before you decide whether you are capturing or not. Thirdly, as Vikram pointed out, excitable gap is an important concept in reentry VT, and the frequency of VTs or the way these are being treated by drug therapy or anti-tachycardia pacing will depend on the length of the excitable gap. If the excitable gap of a reentrant circuit is large, of any PVC is, if it is timed critically, will be able to initiate it. And so you are likely to have very frequent VTs and sometimes incessant VT. And similarly, if you give ATP, your chances of entering into the likely to terminate ATPs. Whereas if the excitable gap is short, the chances of it having more frequently occurring is much lesser. And again, ATP terminating it is also, these success chances are reduced. And then there are more questions in the chat box. One of them is, what is anisotropic conduction? Now, as Vikram pointed out, the majority of the conduction occurs in the longitudinal direction of the muscular architecture in the cardiac muscle, but there is some side-to-side conduction also, which is known as the anisotropic conduction. And because of the gap junctions and different cell-to-cell coupling, this anisotropic conduction is much slower than the end-to-end conduction. It's just like if you are traveling on a road, driving on a road, whenever if you are on a highway, you will drive very fast. But if you have to take a U-turn or turn to the right, you need to slow down. So it is the same situation in the cardiac conduction of an impulse in the cardiac muscles as well. Another question is, what are the variants of bundle branch, reentry, and VT that have been described? So in patients who have bundle branch reentry, usually the baseline conduction is slowed, and they typically have bundle branch block at baseline also. And usually if they have a left bundle branch block at baseline, the VT which occurs is again bundle branch reentry VT is similar to the baseline ECG. So we'll have a left bundle branch block type of pattern during the bundle branch reentry VT also. There are other types of bundle branch reentry wherein you have conduction occurring from one fascicle of the left bundle branch to the others, that is from left anterior fascicle to left posterior fascicle, and these are known as interfascicular reentry and VT. And the right bundle branch block will be seen during baseline as well as during the VT also in these patients. So it is important to establish what is the exact VT circuit is before you can decide where you need to ablate to get rid of this VT. So left bundle branch block pattern of VT means that the antegrade conduction is occurring over the right bundle and retrograde over the left bundle. And if you have a right bundle branch block type of bundle branch reentry, the circuit is reversed. Similarly, the right bundle left axis pattern during a interfascicular VT means that your antegrade conduction is occurring over the left posterior fascicle and antegrade over the left anterior fascicle. Another question is, how do you explain the role of regional and temporal heterogeneity of refractoriness to initiate VT vis-a-vis sustained monomorphic VT versus polymorphic VT? Now, as Dr. Narasimhan pointed out, different types of VT have different mechanisms, and it is important to understand what the underlying mechanism is. In certain genetic conditions like Brugada syndrome or long QT syndrome, what we have is polymorphic VT or VF, and that is usually initiated by heterogeneity of refractoriness and conduction in different parts of the left ventricle or right ventricle and the different segments of this myocardium, whether it is endocardial or epicardial. And this heterogeneity in refractoriness actually results in different parts of the myocardium having occurring at a different time of the action potential, and this somehow tends to initiate reentry, resulting in polymorphic VT or VF. And next question is, how accurate is 0.5 volt and below is SCAR? Now this is typically again for electrophysiologists. When we map the substrate, we keep a cutoff of 0.5 volt and below is considered as SCAR, but there is no actually sacrosanct definition of 0.5. It is just an empirical value that has been taken in most of the studies and cases. But the idea of what is SCAR is basically depending on the absence of any excitable tissue. And typically the best surrogate is looking at the electrogram voltage, which we typically keep it as 0.5 volts for an endocardial map. And some other authors have also, investigators have also used total absence of capture when we pace at high output as considering as definition of SCAR or maybe dense SCAR. Then ATP, how does ATP work to terminate the VT? This question has been asked by Dr. Ashish for Dr. Claire. So maybe Dr. Claire, if he's there, would like to explain it. I think is not there. So maybe ATP again. Dr. Claire, would you like to explain how?
See, when we use ATP, that you are pacing the ventricle on a cycle length which is shorter than the VT for a couple of beats. You have captured the total myocardium with pacing. That means you have for the transitory thing, you have overdriven the ventricles with your pacing. and when you stop pacing with the hope that the VT circuit has been eliminated, at least transitory. So when you stop pacing, then you expect normal sinus rhythm to come. But sometimes VT can restart. It's not something that it will work every time, but the studies have shown that in at least in device patients, that 80 to 85% of the monomorph VTs can be pace terminated if the device is programmed appropriately.
Yeah, so next is ideal site for ablation of a fascicular VT. Now again, fascicular VT, the reentrant circuit has been very well defined, but there are a lot of variations in the reentrant circuit. And typically what we believe is there are different approaches to ablation, but the best approach is looking at the potentials. Now in the reentrant circuit, if you are at the target site, you will see a pre-potential and a Purkinje potential just before the onset of the QRS. And the best site which achieves this successful ablation is wherein you find both the pre-potential as well as the Purkinje potential. And once you start ablating during sinus rhythm, you see some kind of an acceleration. And if you're ablating during VT, you find immediate termination of the VT. And then you reinduce it and see whether you have eliminated the VT circuit. And you also find certain changes in the sinus rhythm ECG to confirm that actually you have got a good successful result. So do we have time for more questions?
No, Karthikeya, I think let's move on in the interest.
Yeah, I think in the interest of time, we'll take it up later. Some of them are advanced concepts, yes. Like deciphering isthmus, whether it's wide or narrow, excitable gap. We'll probably revisit them once the cases are presented.
That's
right. Thank you. I think we'll move on to the case presentations. I would like to invite Dr. Muthaiya first, who will be presenting us a patient of a post-infarction VT. Muthaiya, please.
Dr. Narasimhan, you can highlight Dr. Muthaiya's recent achievements to the DMDNB.
Yeah, it's indeed a pleasure to tell you. Muthaiya is one of our colleagues, extremely focused and hardworking. He has recently won the award as the first clinical research award in European Society of Cardiology Heart Failure Congress. There are totally 900 abstracts that were presented. And his was invited to be presented as for a Young Investigator Award, and he won the award for his work on non-obstructive, hypertrophic cardiomyopathy, non-obstructive substrate, where he showed that SGL2 inhibitors significantly improved the diastolic function on follow-up. So big congratulations to Muthaiya and welcome.
Thank you so much, sir. I hope my slides are seen.
Yes.
Okay, I'll just start. I'll be presenting a case of monomorphic VT after a myocardial infarction, and we'll try to highlight a few concepts through the process. So this is a 55-year-old male, Antrovol MI in 2003, thrombolized. EF was 45% at that point in time, NYHA class 2 to 3. In 2019, EF was 30% and the LAD territory was akinetic. He received a primary prevention single chamber ICD, and subsequent to this, he had multiple admissions with a wide complex tachycardia. So these were his ECG during one of these admissions. So you can see it's a wide complex tachycardia. The rate is approximately 150 per minute. There's a negative precordial concordance from V1 to V6, and there are signs of AV dissociation on the rhythm strip. So this is a ventricular tachycardia. And the QS pattern from V1 to V6 tells us that the exit of this VT is likely to be apical. But just a note of caution when we try to really localize these VTs in patients with extensive structural heart disease, such as this person. So this is his echo. You can see the 4-chamber and 3-chamber views. The LAD territory and segments are akinetic. EF is around 33%. There's a grade 2 diastolic dysfunction and a preserved RV function. So This was his echo from 2015. So just a few definitions before I continue with the case. So an electrical storm is basically a clustering of ventricular arrhythmias in a short amount of time. And the specific definition is 3 distinct episodes of a sustained VT or VF within 24 hours. And if a patient has an ICD, they need to have more than 3 appropriate device interventions within 24 hours. And the prognostic significance of electrical storm is that there is a multifold increase in mortality in the first 12 weeks following an electrical storm. So identification and management of these patients are crucial. So there are a few things to consider when we initially manage a patient with an electrical storm. First of all, it's very important to rule out reversible causes, such as electrical imbalances, ischemia, decompensated heart failure, and infections. And these account for roughly about 10% of the causes of an electrical storm. The other things to keep in mind is that we initially need to risk stratify these patients based on their hemodynamics, their systolic blood pressure, their baseline LV function, and their comorbidities in sense of coexisting severe pulmonary or renal dysfunction. So these are all high-risk patients and they require immediate stabilization. And the last thing to keep in mind is also it's important to understand the hospital that the patient presents at, the expertise that is available, and the facilities. But regardless of wherever we work, there are usually multiple options to manage these patients. The options range from drugs, procedures such as overdrive pacing and an intra-aortic balloon pump, general anesthesia, and other options as well. And we'll try to cover a few as we did with this patient. So this patient had a blood pressure of 110/70 and initially peripheries were warm. Patient presented with multiple ICD shocks, so it was an electrical storm. We tried IV amiodarone and IV lidocaine. Still VT persisted. Patient was anesthetized and ventilated. Still the VT persisted. We attempted overdrive ventricular pacing, which we'll get into from the ICD itself. Still VT persisted. I tried with an IABP, still VT persisted. And as we see with most cases of electrical storm, there is a cascade of hypotension. We add inotropes. There's a low cardiac output states, and the metabolic acidosis climbs. So it's usually interventions have to be done. So there's often a debate on what to choose in terms of whether IV amiodarone or IV lidocaine is useful as an initial therapy.
Requesting everybody to silence their mics. Please mute yourself.
So although amiodarone has multiple mechanisms of action, in an acute setting, it's the beta blockade action that takes over. That's why it's a very effective drug in the short term and long term treatment of an electrical storm. There's no head-to-head comparison of amio versus lidocaine for an electrical storm setting, but we do take some data from patients with out-of-hospital cardiac arrest. Initially, it was shown that amio was better. Recent data shows that there's probably not much of a difference. The only thing to keep in mind is lidocaine preferentially works in the...
Can you pause for a minute? May I request everyone to mute themselves, please, except the presenter.
Yeah, there's a lot of
background noise.
Interference coming. Yeah, please. Yeah.
Please go ahead.
So just to mention that lidocaine preferably works in the ischemic myocardium. So it's useful in the MI, post-MI settings. But in a non-ischemic setting, the effect of lidocaine is not so much. And another common question is which beta blocker is better? Now, in general, the class effect of beta blockers is to suppress the adrenergic tone, but you do have non-selective beta blockers such as propranolol. And because of its lipophilic properties, it can penetrate the CNS and you can block the presynaptic adrenergic receptor. So this is probably one of the reasons why propranolol was found to be more effective than metoprolol in an electrical storm. So role of overdrive pacing, I think Vikram and Karthikeya sir spoke about the usefulness of overdrive pacing in a reentry circuit. So it can be done two ways in this patient. It can use either we can put in a temporary pacemaker and pace the ventricle at a slightly higher rate than the tachycardia cycle length, or since the patient already has an ICD, we can manually deliver pacing stimulus similar to what an anti-tachycardia pacing works. And this is just to show a few things. On the right side, this is just to show that all programmers, we can actually manually deliver the pacing stimulus and simulating anti-tachycardia pacing. And this is the concept Claire sir was telling that you have a reentry circuit, you have the green represents the electrical, the excitable gap, and blue represents the refractory tissue. So if you have a pacing stimulus, be it a temporary pacemaker or an ICD lead, a correctly timed stimulus, if it meets the front end of this electrical excitable gap, you can extinguish both antigradely the wave front and retrogradely meet the refractory tissue, and this can abolish the circuit. So this is how overdrive pacing works. But in this patient, we were not able to reach much success with that as well. Another option that is now available in most hospitals is that we can use neuroaxial modulation. And there are now multiple ways that we can suppress the adrenergic tone through this autonomic modulation. You can have percutaneous stellate ganglion block is either done on the left or bilateral sides. It can be done at bedside with the use of an ultrasound. The injection is of bupivacaine, and this has shown a good control in ventricular arrhythmias. It usually buys you a good amount of time to stabilize the patient. And with regards to VATS guided cardiac sympathetic denervation, we have a recent publication from Yash Sir's group that has shown good long-term results and freedom from ICD shocks after 2 years. So there's only a few cautions that need to be considered when we select patients for these, especially patients with RV dysfunction. So in this patient, after we anesthetized and intubated the patient, actually the rate of the ventricular tachycardia reduced, but still VT persisted. And this is I just wanted to bring in the definition of an incessant VT, which is basically when VT recurs or sustains after electrical, pharmacological, or spontaneous conversion to sinus rhythm. And a small difference between this ECG and the previous ECG is the small difference in V1. And this, as Vikram showed in his diagram, can occur in patients with a large substrate where the exit site of the VT slightly changes. And I think Vikram has already gone over this. In a post-MI setting, a broad approach to an ablation, if we decide to do an ablation, is to first find out which are the areas of scar and identify these abnormal EGMs. We will try to induce VT, and two things can happen. Either the patient becomes hemodynamically unstable, or the VT is non-inducible. In either of these circumstances, this VT is considered unmappable, and the strategies are different. If the VT is mappable, we try to do entrainment mapping and reach success through that. If the VT is not mappable, then we try to do targeted substrate and looking at the late potentials that he described with base mapping. And just one concept I'd just like to share is, so once, as he showed you a picture with that catheter in the myocardium, so you have a picture of your myocardium, you have areas of scar which represent the anatomical blockade that he spoke about, and you have this isthmus region or slow conducting zone, and this is basically fibrosed area with a few viable myocytes. So what happens is when you have an impulse passing through here, it passes through the isthmus very, very slowly. So what you see when you record these signals is that you see that the QRS comes first, and that this area with the slow conduction reaches at the much later. So that is why these are called late potential. It is because of the slow conduction here. And this is something we target because these are the areas that are usually the substrate for reentry in these patients post-MI. So these are just some examples just to show what late potentials are. You can see the QRS gets over, and there is some signal that is left over after the QRS. So this represents late potentials. Sometimes you can have multiple late potentials after the QRS, and we use other maneuvers to find out which of these late potentials are significant. And this is what Vikram showed again, showing that you can do pace mapping to find out only the exit of one of the exits of the ventricular tachycardia. And pace mapping requires you to first store the VT morphology, as in this patient, pace the ventricle, and see what is the match between this VT morphology and the paced QRS. So a good match tells you that this is one of the exit sites. It doesn't tell you much about which is the area of slow conduction. And this, I think, has already been discussed. Just wanted to highlight that the voltage area, like Karthikeya, as I said, number is set as 0.5, but it can vary from patient to patient. And dense scar is usually less than 0.5, and more than 1.5 is healthy tissue. Again, this refers to endocardial voltage, and these cutoffs range from the chamber and the area of the chamber that you are mapping. So once the electrical storm is treated, few things you need to keep in mind is the patient needs appropriate device programming, and this can depend on the patient. The detection windows, how you program the anti-tachycardia pacing also matters. What kind of drugs are you going to continue the patient on after therapy? And there's a recent publication that said that after a successful VT ablation, it's probably better to reduce or even discontinue amiodarone for the long-term side effects. And it's important to optimize the other heart failure and comorbidities of these patients. So this patient was arrhythmia-free for 2 years after the ablation. And VT storm has a high mortality, but catheter ablation in a selective subset of patients, it's an effective therapy. And before taking the patient for ablation, systematic planning is essential. So I'll stop there. Thank you so much.
Thank you very much, Muthaiya. Open this for discussion, or we'll finish the second case. Karthik?
Yeah, I think so. Let's finish the second one and then.
Okay. Can you ask Vijay to share the screen and start? Vijay Shekhar is again a colleague of ours who's going to present to us about another patient with incessant VT due to hypertrophic cardiomyopathy. Vijay, recently done.
Sir, good morning, everyone, and thanks for the wonderful opportunity. So I'll start with my case presentation. So the history starts with a 58-year-old male who is a known case of hypertrophic cardiomyopathy and is on medical therapy for almost the past 8-9 years. And he presented.
Can you go on full screen? Can you go on full screen?
Yes, sir. Just a minute.
Go on full screen, please.
Now, sir?
It's full screen.
It's full screen, sir, now?
No, you have that next slide seen, no? That is.
No, you need to go to your full screen mode from
Display settings.
view options.
Left upper display settings.
Yes.
Okay, good.
No, don't go to duplicates here. Go.
Yes, sir.
Yeah.
So this patient is a hypertrophic cardiomyopathy patient who is on medical therapy for the past 8-9 years, and he presented to us with the recurrent palpitations and pre-syncope with borderline blood pressures. So this is the presenting ECG, the 12-lead ECG. So it is a wide regular wide complex tachycardia, and the QRS is wide, almost measuring 200 milliseconds in certain leads, and suggesting the possibility of a VT. And additional features that favor the diagnosis of a VT in this ECG is the northwest axis that is evidenced by a positive QRS in AVR. And not to be missed in this ECG, again, is the AV dissociation on the rhythm strip. So additional features are like this patient has an RBB morphology of a VT and presence of a monophasic R wave in the presence of an RBB morphology, as well as QS complexes in V6 all favor the diagnosis of a ventricular tachycardia in this patient. So moving one step further, we will try to localize where the VT is arising from, or the site of exit of the VT. So again, the first step is to determine the chamber of origin. The V1 gives you a clue to that. If it is a right bundle branch morphology, it is probably arising from the left ventricle. Then the second is to determine whether the VT is arising from the base or the apex. We look at the precordial lead transition. The presence of QS in V2 to V6, predominant QS complexes are seen arising from V2 to V6. That shows the wavefront is traveling from the apex towards the base. The third thing is to look at whether the VT is traveling from the septum or the lateral wall. So here we look at leads 1 and AVL. QS in AVL suggests the wavefront is moving from the lateral wall towards the septum. And again, last is to differentiate whether it is from the anterior or the inferior wall, where we look at the inferior leads. A positive R wave in AVF suggests the wavefront moving towards the inferior leads from the anterior aspect. So summing up, the patient has a monomorphic VT that is likely to arise from the LV apex, from the apico-anterolateral region of the LV apex. Again, as said, the value of localizing, especially in a patient with structural heart disease, has to be taken with a pinch of salt. So this patient continued to be in VT storm in spite of multiple antiarrhythmic drugs and DC shock. And I think Dr. Muthaiya has already explained in detail of how to manage, go about a VT storm. We have tried all these treatment aspects in our patient. And importantly, there are some rhythm strips that are available here, which gives important clues to the underlying diagnosis as well. So I'd like to highlight two important features. One is this VT is of a sudden onset. That is, the onset of VT is not preceded by a VPC or a short cycle. And the second feature is that the first beat of the ventricular tachycardia is similar in morphology to the subsequent beats. So these two features, that is the sudden onset of the ventricular tachycardia as well as the first beat resembling the rest of the VT, points towards that this monomorphic VT could be likely due to a scar-related re-entry mechanism. Again, there are some exceptions to the rule, but it more often suggests that it is a scar-related re-entry. So this patient continued to have VT in spite of all these shocks and antiarrhythmic drugs. And this is again an interesting finding that we picked up in our patient. So after the cardioversion, this patient had profound ST elevations in the inferior as well as the anterolateral leads. Coronary angiogram was also done in this patient, but that turned out to be normal. So what is the exact mechanism of ST elevation in this patient? It can be explained by the phenomenon of electroporation. Because after an electric shock, what happens is the region that receives the shock maximum, there is a temporary disruption of cell membranes that alters the flow of ions across the cell membranes. So there is a set of, myocardium where an electroporated myocytes that have a depolarized diastolic potential, and another set of myocytes that have a completely normal potential. So this dispersion leads to the ST elevation. So this picture I have put up from an endocardial shock. So here you can see in the endocardium, there is a altered depolarized diastolic potential and an altered action potential, whereas the epicardium is completely normal. So this difference in the action potential morphology as well as the depolarization wavefront results in the transient ST elevation. So this ST elevation post-shock is higher with the use of monophasic currents than for biphasic. And if the duration of arrhythmia is longer, then the patient is likely to have a post-shock ST elevation. And if propofol is used as a sedative for DC shock, because of its properties on the invert calcium channels as well as the invert sodium channels, all these factors can result in a post-shock ST elevation. Of course, this phenomenon is quite transient. It usually resolves within a few minutes. So this is again the post cardioversion ECG where the patient is in sinus rhythm with the ST changes settled. So in the background of HCM, the ECG correlates well where there is a fractionation of the QRS complexes and there is also ST coving with T-wave inversions in the anterolateral leads. So we move on to identifying the substrate that caused the ventricular tachycardia. So the echo is a classical representation of a midventricular obstruction along with an apical aneurysm. We can see that the midventricular cavity is almost obliterated due to the severe hypertrophy that is being present. And of course, also quite obvious is the apical aneurysm that is clearly seen. So this again is a color flow image and a pulse Doppler image showing that there is flow turbulence in the region of the midventricular cavity and also a diastolic flow is detected in the region of apical aneurysm. And the continuous wave Doppler shows that there is a obstruction in the midventricular, a significant obstruction. And there is a mid-systolic dip in the velocities that is indicated by the arrow, which has been described as a lobster claw pattern in some of the journals as well as the textbooks. We proceeded with an MRI for further risk stratification. The MRI picture shows a classical hourglass appearance due to the severe midventricular obstruction. And also important is that the MRI demonstrates the subendocardial scar in the region of the apical aneurysm that forms the substrate for the ventricular tachycardia that the patient is suffering from. So now this subset of patients, that is a midventricular obstructive variant of HCM along with an apical aneurysm, represents almost 8 to 10% of HCM patients. Understanding this subset is important because they have a poorer prognosis compared to the other subsets, because they are at higher risk of developing heart failure, arrhythmias, as well as thromboembolic events. So there is a multifaceted approach needed to manage such patients. One is we have to take care of the mid-cavitary gradients, where we have options of medical therapy, ablation, surgical options, and also role of pacing that I will subsequently discuss. But our primary importance in this patient is to get rid of the ventricular tachycardia. We have exhausted all our medical therapy options. So the next way to go about this is to consider RF ablation in this patient, and also give an implantable cardiac defibrillator for a secondary prevention. So if we look at the data of RF radio frequency ablation in this subset of patients, that is HCM with apical aneurysm, this is a study where 15 patients underwent an RF ablation. So the study demonstrated that there is a characteristic ECG pattern in most cases that is indicated by the presence of a northwest axis and a QS in precordial leads. Our patient also had a classical ECG pattern, and the mechanism of VT is more often a reentry circuit that arises from the apical aneurysm, and it is a scar-related reentry. So we can approach this scar either endocardially, or an epicardial approach may be required in certain patients. And considering the underlying substrate, which is HCM, there is a high recurrence rate. And in this study, the recurrence rate was close to 20% at 1 year, which is an acceptable or a satisfactory outcome. So this, I think, has already been discussed in detail by Dr. Vikram as well as Dr. Muttaya. So here, our plan was to go ahead with the substrate mapping and pace mapping. So this is just to depict that there is a good angiographic, MRI, as well as a 3D anatomical correlation. The first picture shows the pigtail shot where the LV aneurysm is being depicted. And again, the MRI picture showing the LV aneurysm along with the scar. And this is a map where you can see that the inner shell represents the endocardial map, which is a completely obliterated LV cavity taking a characteristic hourglass appearance. So all these correlate well and suggest that the apical aneurysm and the scar-related reentry as the mechanism of ventricular tachycardia in this patient. So this, again, we have done a substrate mapping. There has been already a discussion about this voltage criteria, so I will not go into this. So this first image on the left side shows that there is an endocardial, this is the endocardial cavity being mapped with the catheter inside the LV cavity. The gray area shows the area of the scar, and the middle picture or the middle cartoon shows a combined map where the inner shell represents the endocardium and the outer shell represents the epicardium. And again, the gray zone that is highlighted by the yellow arrow represents the area of the scar and the area of interest for ablation. So here in this patient, we did an epicardial ablation where the catheter is introduced through the pericardial cavity, and the catheter positioned in the region of interest, and ablation lesions were delivered. So apart from this patient also received an ICD after 48 hours. The ICD in this patient serves two important purposes. One is for secondary prevention of sudden cardiac death. And the other thing is, with RV apical pacing, we were also able to decrease the gradients. So this cartoon in the continuous wave Doppler in the middle frame shows without pacing that there is a significant gradient in the midventricular cavity. And again, this is the right one showing that there is a complete abolition of gradients when we are able to pace from the ICD lead. So pacing again abolishes the mid-cavitary gradients in this patient. So this patient was successfully, the mid-cavitary gradients, we started them on beta blocker therapy as well as disopyramide, and also pacing has been offered. So these two things take care of the mid-cavitary gradients. The arrhythmia has been successfully controlled by an epicardial RF ablation, and an implantable cardiac defibrillator is also been given for the patient for secondary prevention. And again, emphasis is on anticoagulation because the risk of thromboembolism is quite high because of the apical aneurysm. So these patients require very low threshold for starting anticoagulation. There have also been isolated and sporadic case reports where for refractory and incessant VT, surgical options like aneurysectomy also was being considered and were successful. So this is again just to highlight the importance of managing HCM patients where the clinical phenotype has to be identified, and there are a lot of pharmacological as well as non-pharmacological aspects depending upon the clinical phenotype. So this article makes an interesting reading, so just put it up here. And so the learning points from this particular patient is to highlight the importance of the HCM variant where midventricular obstruction and apical aneurysm represents substrate where they are high risk of arrhythmias, end-stage heart failure, especially because of the aneurysm resulting in a systolic heart failure. And VTs arising from this subset of patients are usually from the apical aneurysm and scar-related reentry, and they can be identified by a distinct morphology pattern from the 12-lead ECG. And when medical therapy fails, RF ablation can be a safe and effective treatment modality in such patients. An endocardial ablation or an epicardial ablation can be performed. In our patient, an epicardial ablation was being done. And again, the role of non-pharmacological measures like the role of ICD for secondary prevention, and also to utilize an apical RV apical pacing to decrease the midventricular gradients has also been highlighted in this case. So thank you all for your patient listening.
Wonderful cases, Muthaiya and Vijay. So we can have, I think, 5 minutes of discussion before we move on to the last case.
Can I ask, am I audible, Karthikeya?
Yes, sir.
Can I ask people, do we know, anybody knows one or two good surgeons to do myomectomy? You know, I have that problem. There are not many people left in India to do good myomectomy in hypertrophic cardiomyopathy.
Hello, Dr. Claire. Good morning.
Morning, Yash.
You had your morning jog, I expect.
Yeah. I'm sitting with that for the.
Okay, so regarding surgery, actually in Mumbai itself, we have 3 or 4 surgeons who are quite well versed with myectomy. I think myectomy is an underutilized modality. But also having said that, it is not every surgeon's cup of tea, because I've seen complete AV block being produced, but experienced surgeons almost never. Even if they get LBBB, they don't go on to develop complete AV block. And I think rather than doing alcohol ablation, saying that we don't have good surgeons, therefore we are doing, I think rather we should identify and encourage people to go for surgery if they are refractory to disopyramide, which according to me is a wonderful drug in younger patients.
Yeah, my concern is only that I don't feel confident with surgeons available, at least in my part of the world. So then, we try septal ablation, but again, septal ablation, not every patient is suitable. Unless you have the artery, you have the same area, you should try. And for mid cavity, I have never tried. Actually, Yadav asked this question on the chat box. I have never tried for the mid cavity, this alcohol septal ablation. Maybe if required, only if you don't respond with medication or with pacing, then surgery is the better answer. I agree with you.
Kerala, so in Kerala, we have Dr. Nasser, who actually left Chitra, and then he is working in Travancore Medicity. He's very good in doing this myomectomy. Kerala.
That's good information.
But that apart, one comment I have is that, I have seen, and I will leave it now to the house and Narasimhan and others, Karthikeya, to discuss at least 3 patients I remember who have died after alcohol ablation. One lady had gone to one of the pioneers in UK to get it done and landed up with a big anterior wall infarct for a mid LAD obstruction. And 2 for post PC gradients exceeding. I think all ablation should be undertaken in the rarest of situations.
Yash, I'm glad you brought this up. We started, can some mute? There are a lot of voices. We started routinely using contrast echo for all patients before alcohol ablation. We were really worried. So noise.
Can you mute this QCOM BT?
उसको सीट रेफरेंस करवाओ। आरएसडी वाली पेशेंट बैठी है ना, फीमेल, वो बच्चे के साथ, तो बोलते सीट रेफरेंस नहीं हुआ उसको, वो छोटे बच्चे के साथ है ना, बायोप्रेस्टेड। हाँ,
Hello. Anyway, see, when we started injecting contrast before alcohol ablation, the number of patients where the contrast was going to the RV side of the septum was quite more than 60% of them. It was layering on the RV side of the septum, which explains the common finding of right bundle branch block in these patients. So the amount of necrosis we cause or an infarction is quite large and quite uncontrolled in a large majority of these patients. Especially if it's in the mid-myocardium, you're creating a new arrhythmic substrate. And I fully agree with you. On follow-up, we have had more problems with alcohol septal ablation. One of the things which we find it very useful for EP person is to, now with contact force, you can do RF reduction of the septum. Now, ideally, this is only for moderate obstruction, moderate thickness. You get about 5 millimeter reduction in the septal thickness. So that is enough to reduce the gradient in a vast majority of patients.
One of our patients developed severe MR after alcohol septal ablation. Have you seen how common is it?
Right. It's grossly underreported. Complications are grossly underreported. I'm glad Yash brought it up in this.
Plus, I think everybody should understand that septal ablation will not do anything for the arrhythmias the patient is having. So even if the main issue is arrhythmias, you need to tackle them, and alcohol septal ablation has nothing to offer for the arrhythmias per se.
I think the HCM is a separate discussion. Maybe once we should have a whole session. Can we move on, Karthikeya?
Yeah, I think so.
We'll now invite Dr. Daljit, who's my colleague, who has a special interest in certain areas of rheumatic atrial fibrillation and device management with patients with heart failure. Daljit will speak to us about optimizing device therapy in ventricular arrhythmias. Daljit, it's yours.
Maybe you need to unmute, Daljit. Your slides are seen.
You have to unmute yourself, Dev.
Oh, sorry, sir. So my talk is on optimizing device therapy in ventricular arrhythmias. This is mainly from DM-DNB students. So I would like to start with how an ICD sees that whether the VT is there or not. So it's as simple as we diagnose it on ECG. For example, it starts with the rate threshold. For example, if the rate is very fast, the device will say that there is some tachycardia going on. Next, the device will go to the number of intervals, for example, which we can set, like whether there is a 28 beats, 30 beats, 40 beats, and after that device will say, yes, it's a sustained arrhythmia which may need intervention. So device will then detect the tachycardia. Following that, device goes to detection enhancement, whether it's a supraventricular tachycardia or ventricular tachycardia. That is also dependent on, like we do ECG criteria. Common is this onset. For example, your sinus tachycardia is slow onset, whereas VT is a sudden onset. Second is common as supraventricular tachycardia in the patients in whom we give ICDs are sick patients and they have atrial fibrillation, which is irregular tachycardia. Whereas VT is a stable tachycardia. So stability is the another criteria. Third, on ECG, what we see is morphology. We always say that if it's wide QRS or the morphology or excess is completely different than the baseline, we say that it's a VT. So same three commonest tachycardia are used by an ICD to diagnose or differentiate VT from the SVT. And once it is confirmed, device says that yes, it is VT, it will give therapy, which is commonest two kind of therapy. One is overdrive pacing, which is called anti-tachycardia pacing, which has been discussed. And next, if it doesn't terminate, device gives shock. This is a typical screen of an ICD. Like commonest, we have three zones, VT1, VT2, and VF. Depending upon the patient's background, we can have 3-zone therapy. We can have one monitor zone where we don't want to miss VT, but we want to know that patient had VT. But I don't want to give therapy for a slower VT, so I can modify therapy in each zone separately. And then I can have single zone, 2-zone, or 3-zone therapy, followed by, as I already told, detection, like number of intervals to diagnose tachycardia. Secondly, this is actually a biotronic screen. So this is if you have a dual chamber ICD, it goes to another algorithms apart from stability, onset, and morphology match to differentiate supraventricular tachycardia from ventricular tachycardia. And then after that, it gives therapy. So you can give separate therapy in separate zones starting from different number of anti-tachycardia pacings and different number of energies or shocks. And when we see a device, these are the typical kind of EGMs which are stored in the device. First one is leadless ECG that looks like that records from SVC coil to the CAN. So it looks like lead 1. Second is from the RV coil. This is called far field shock EGM, which is from RV coil to the CAN, and it is also like a surface QRS but different. And then this morphology match uses this E-gram. Third is your near small, this bipolar, like it is ring to tip. It's a near field which is used for sensing the tachycardia. And last is the marker channel, like which tells you that what device is seeing. So these are the 4 classical EGMs which are stored in the device. So I would like to start with the case example. This was a 64-year male, HCM, dual chamber ICD given for secondary prevention of SCD. This guy got a shock, and after getting the shock, so patient was told that it's good that you got the shock. That's what ICD was given for, and now you have recovered. Let's walk through this. So if you see, this boxes are A, this rounds are V, and this is the cycle length of VT 360. And if you see that this is the milliseconds, and if you see boxes are much faster than the round ones. So that means this A is much more than the V. So when A is much more than the V, that means it's a supraventricular tachycardia, which device has misdiagnosed as VT, although after shock it has been reverted. So it's an atrial tachycardia which has been reverted after shock. So am I happy with this? The device has given shock and tachy has been reverted. Next, one more case example I'd like to show is, there's a 60-year lady, ICMP. This lady was given a device, and immediately after device, post-CAT, she got a shock. And the patient was started with amiodarone for that shock because she got a shock from the device and the device is fired. If you see, I've already told, the upper one is a near field EGM, and which you see that this is a QRS, and the rate is almost like 75-80. And if you see the lower one, there is some noise going on. And this noise, device has diagnosed FS is fibrillation sense, and device has diagnosed it as ventricular fibrillation and given a shock. So this is a wrong shock. This is inappropriate shock. So any patient who gets therapy, it's not like you should always go through the device EGMs before giving therapy to the patient. We should know whether the shock is appropriate or inappropriate. So what do you mean by inappropriate shock is? Any therapy given by the ICD, any shock given by the ICD which is not for VT or VF is an inappropriate therapy. So for the first case, the therapy was given for supraventricular tachycardia. That was inappropriate therapy. Second case, the therapy was given for noise. That was completely inappropriate therapy. So how do we reduce shocks? Most important is both inappropriate and the appropriate. So wait a minute, why I am talking about reducing the appropriate shocks? Because the notion is the device is given to give the shocks. We have implanted the ICD so that the device can give shock and save the patients. So the commonest notion is it is meant to give the shock and treat VT. Please remember, ICD shocks, although they save lives, but they are without sedation and they are out of hospital, and they are really unpleasant to the patients. In the hospital, when the patient comes, we give shock. Most of the time, we give good sedation. Even if we are not in a condition to give sedation before shock, we give shock, and after shock, we immediately sedate the patient so that patient doesn't remember that episode. So what are the outcomes? Why do we want to decrease the number of shocks, both appropriate and inappropriate? One is especially inappropriate shocks. They are pro-arrhythmic and they may increase the mortality. They are associated with higher mortality. And if the shock is given, whether appropriate or inappropriate, psychiatric disturbances, and they impair the quality of life. And most important, one of the added thing is the premature depletion of the battery, because many patients we get that they have got 100 shocks to 200 shocks and it deplete the battery and patient has to undergo another procedure. So how do we decrease the number of shocks? Is by utilizing ATP extensively, overdrive pacing. They are painless. Mostly patients are not aware. Few patients, they can feel ATP also. They improve the quality of life and then they can lengthen the battery life. So there is already an extensive data, especially for comparatively a slower VT of less than 200 rate. The success rate of ATP is 85 to 100. But of course, sometimes when you give atrial overdrive pacing, it may degenerate into VF and the device has to give shock. But most of the VT gets converted slower VT with atrial overdrive pace, with the anti-tachycardia pacing. And there is a data that fewer, faster VT, less than 250 rate, if they are monomorphic, can get converted with ATP, so that one ATP can be programmed in a zone between 200 to 250 also. I would like to show a case example of this lady, 66-year lady, old anti-wall MI, VT. She was shifted on ventilator with VT storm. This was the morphology of the VT, and it was told that device could not recognize this VT. Patient was on amiodarone, lignocaine, hypotensive patient, and was in refractory heart failure. And most important for us to know is, and they gave outside shocks from the outside. It used to revert and restart. Why this VT has been not detected by the device? It's important thing to know is it's little slower VT. To see the rate is around 120 to 130. So usually the notion is we don't give therapy for the slower VT. That's why the settings would not have been done to identify this VT. So anyways, when we saw the first thing, you can see the patient is in multi-organ failure. Liver enzymes are deranged. Kidney creatinine is deranged, platelet counts were low. Her previous EF was around 35, now dropped to 15 to 20%. She was in refractory heart failure. In emergency, when patient reached, the first thing which was done, I think Muthaiya already showed that from the programmer, directly you can give therapy. And can you see this? We have done an overdrive pacing, and the first time you could see a sinus ECG of this patient after 4-5 days. And now it's reverted. So we are happy now. The VT has been reverted. Patient will live. So now if you can see that typical settings in this particular case, which is not usually done, is VT1 zone we have kept as 105 to 120 and only ATP therapy, no shock here. VT2 is 150 to 206, extensive ATP therapy, and after that lower Joule shock. So when this was done, patient was shifted to ICCU. We are satisfied. Morning I went for the round. I asked sister. Sister said she's doing better, was still on ventilator. No VT, she said. But when you see the device, if you go through this log, September 15, 2016, 10, 27, 26, 25, 24, every minute, the slow VT, every minute there is a VT, although it reverts with ATP, but it restarts immediately. And when you see over 12 hours, can you see the number of VTs are 255, 255 ATPs delivered, VT2, 3, maximum are reverted with ATP. So over this time, she received only 3 shocks. All are reverted by ATP. But yes, with maximum therapy, with all the background, we cannot leave this patient like this because she's almost consistently in the VT. Anyways, this patient was taken up for procedure. You can see an activation mapping was done because she was continuously in VT. This is septal area. This is RV, which was transiently mapped, and it was from the septum. You can see this is an area where it was ablated. Post ablation, this was a first X-ray when she came. This was an X-ray at the time of discharge. And you can see over week, by the time we discharged, she improved drastically. Her all parameters improved drastically, and her EF improved to 35% again, and she was discharged home. So what are the causes of this? We were talking about the appropriate shocks. What are the causes of inappropriate? Commonest cause of inappropriate shock is supraventricular tachycardias. And out of that, commonest is atrial fibrillation, atrial flutter, followed by other supraventricular tachycardias like sinus tachycardias and other inappropriate shocks. So what happens when we give ICD for primary prevention? They are more sicker patients. They have more LA enlargement. They have more chances of atrial fibrillation. That's why more chances of inappropriate shocks. Whereas in younger patients, where we give device for channelopathies or for non-ischemic cardiomyopathies, the causes of inappropriate shocks is usually sinus tachycardia because they are doing normal activities running around. So the sinus rate goes up to 160, 180. So sinus tachycardia is one of the reasons for younger patients. So what is the answer to how to decrease these inappropriate shocks? Is dual chamber ICD an answer without a pacing indication? I would like to show a case example of this patient. He was a young case of Brugada syndrome. Case was done in Saudi Arabia. Patient was getting multiple shocks, came to India, and he used to tell that every time I play with my son, I'm playing, going out, I keep getting shocks. And if you see, there is an atrial channel, there is a ventricular channel, this is a far field channel, and can you see it's AV, 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 AV. This is a sinus tachycardia. Despite of dual chamber ICD, device has diagnosed because it has gone to a VT2 zone because they had kept this rate as a VT2 zone. It has given a therapy, ATP first, tried overdrive pacing and then shock. That's why he was getting repeated shocks. So if you see there's a data saying that more than 50% of ICD implantations in US is dual chamber ICD, which is without pacing indications. And the reason is for better arrhythmia discrimination and to decrease the number of inappropriate shocks. But data doesn't say that. Data is inconclusive. So how do I decrease the number of shocks? One is avoiding therapy for a slower VT, but keeping the monitor zone on so that I should know that slower VT, each patient is different. Slower VT, patient is having a slower VT and needs therapy. Or if I give for primary prevention, then I have to give therapy for a rate of more than 180 or maybe 200, especially for channelopathies, we should keep at a single zone therapy of more than 200. Second, longer detection intervals so that non-sustained tachycardias, we can give some time to self-terminate. When we talk about overdrive pacing, there's a word of caution. Certain things we should know about overdrive pacing is very fast VTs or VF, overdrive pacing may not be working. Second, sometimes I have seen patient comes implanted in another centers, they come, a number of impulses has been kept as 3, 4, 5. So number of drive train. I think Muthaiya and Vikram both showed nice EGMs where it takes time because your lead is in the RV and the VT is arising somewhere else. It takes time for the VT, for the impulses to enter the circuit and train and terminate. So your number of impulses are very important when you plan for overdrive pacing. Last is temporal proximity of the pacing lead to the re-entrant circuit. Where is the circuit and where is the makes a huge difference. For this, I would like to show a small case example. This was a lady, 35-year female, myocardial tuberculosis, came with VT storm. And if you see this case, actually quite robust overdrive pacing. VT was not that fast. Device was giving lot of ATPs, but it was never terminating with ATP and always recurring a shock. Why this has happened? Actually, because she was in VT storm, this multi-drug resistant, we took her for the procedure, and if you can see, the VT was an epicardial VT. This is I've calculated maximum deflection index, which says that if initial deflection is like a pseudo delta is there, initial deflection is very, very slow as compared to the distal. It is a marker of one of the marker of epicardial origin of the VT. And I'd just like to show that this is the lead position. This is your RV septal lead, and this is the origin of the VT. So the distance between your lead and the origin VT, which is far, that may be the reason that ATP is not able to terminate in this case, ventricular tachycardia. Last, I would like to say just one more case example. This was a case, ischemic cardiomyopathy, given a CRTD in March 2019, declared at CRT non-responder, was on maximum medical therapy, recurrent heart failure hospitalizations with renal dysfunction. This was the ECG of the patient when we saw the patient first time. If you walk through this ECG, this is the only paged complex, initial R in lead V1. This is the intrinsic beat somehow. This is the PVC, I'm sorry. This is the PVC. And the post PVC, I think this is faster than the maximum tracking rate. The device has not tracked it. So this phenomenon was getting repeated, and the patient was not getting adequate biv pacing. We all know that for the adequate function of the CRT, the percentage of biv pacing should be more than 99%. And moreover, these PVCs were not getting suppressed with medical therapy. With any of the modifications in the CRT, we're not able to increase the LRL to 90 also, but we're not able to suppress these PVCs. This is just, I switched off the CRT, just wanted to understand the morphology of the PVC to localize it, to take the patient for the procedure. It's a QR complex in V1. So this is, I think this nice E-grams are shown, this is fractionated, this early, it's an activation mapping was done. You can see this is a site from where the PVC is arising. And this is a place where we just started ablation, and there's a PVCs and it's suppressed immediately. And there's a site, so transeptally we go and there's a site where we have ablated, and you can see it's a beautiful ECG after that. You can see now it's a biv pacing going on, no PVC, clean ECG, and after that it's been 2 years, there's no heart failure related hospitalizations for this patient, and renal function has been improved. So I just want to emphasize this, that device implantation is not the end, it's the beginning, because we should understand the nuisance of the devices when we have implanted. Secondly, ICD is given for an emergency. We should not be happy that the patient is getting lot of shocks. Whenever there is a shock, we should go through the E-grams to understand whether it's appropriate or inappropriate. Even if it is appropriate, can I do something to decrease the number of those appropriate shocks? This is my last slide. The reason I have kept this is because this patient with an ICD was shifted from another city, saying patient is in VT storm with multiple N number of shocks. Patient was on amiodarone infusion, saying that VT storm, and if you can see, these are all inappropriate. This lead has been dislodged. So no baseline ECG was done to see whether actually patient has VT or not. So knowing whether the shocks are appropriate or not appropriate are very important. So we know that technology is evolving, but we should know how to use it. Thank you.
Thank you, Daljit. I'll ask Dr. Claire to take over.
Well, I think Daljit has really given this subject very good insight, and I think I 130% agree with her. The device implantation is not the end; it's really beginning. I have always insisted, and I think that ICD implantation, CRT implantation should be best left to the electrophysiologists. We don't have any regulation in our country. Many of the cardiologists